Hello, everyone. This is Case 1 Debrief for CB4. So first of all, I think the class overall did really well from what I heard from the facilitators. So good job. I am glad to hear that, hopefully the experience from CB3 were translated a little bit to CB4. We're going to have a lot more cases this semester. Hopefully you get to see more practices, especially in the electronic health record, to see how it looks like and practice your skills a little bit more to figure out how you can work up your patient faster from the EHR. So a few things that I would like to cover for the debrief, again, similar format as my debrief in CB3. I divided into therapeutics, clinical proles, and lastly, announcement, mostly for the classes. But let's kind of go over some of the points for therapeutic first. So I hope it was being asked and being discussed during the discussions. And this is very important, right? In terms of, why we take phosphate binders with meals. And specifically in this case, the patient was taking sapolomere. And it's very important that we mention to patients that, they should take it with meals. And the reason behind it is you have to take a look at the mechanism of action. And this applies to like other medications too. And that's why it's very, very, very important that you know how the drug works, how the drug got absorbed, how the drug got metabolized in the body, just because those are some of the important components to know how the drugs will best work for the patient. For the case of phosphate binders, in this case, it acts by, as its name is, binding on the phosphate, right? And you're taking the phosphate binders oral. So they're actually binding the phosphate on the food that you take. So if you're not taking any food or eating any food, there's no phosphate to bind, right? The phosphate that it doesn't really get rid or excrete any of your phosphate in the blood that's already in the body. It's just help you to decrease the absorption of the phosphate that is incoming. So again, knowing how the drug works, very, very important in terms of how we need to instruct the patients to take the medications. I've seen this a lot in the clinical setting where, phosphate binder might not work and maybe the patient is just not eating, right? Like we are asking them to eat it with breakfast, but I don't really eat breakfast in the morning, so it's not going to work. It's just going to add more burden on the patient, pill burden, right? It's just going to add more cost to the patient, something that is not going to be efficacious for the patient. So again, think of the patients when you're recommending something. Make sure that you're educating them how to appropriately take it so they can actually optimize their regimen and manage their chronic conditions. The second questions I have with therapeutic is, this is one of your classmates, one group of students who came up, which bring up a good point, bring up a good questions regarding cefazolin use for this patient. So if you look at their cultures, it came back that the E. coli is susceptible to cefazolin. So can we use it instead of, doing ceftriaxone, right? So when you're selecting antibiotics for patients, you need to first, definitely you need to know what kind of bacteria we are trying to cover, right? And that's the first step to get into selecting your antibiotics. And then for the antibiotics, you need to know the spectrum of antibiotics. When you're thinking about cefazolin, which is first generation cephalosporin, it is a first generation, right? So when you look at the spectrum, it mostly cover gram-positive. So spectrum means like, it's, when we're talking about spectrum, it's basically what do they cover best? And they might cover Adenovirus, here and there, but it's not the best. And then ceftriaxone, your spectrum kind of goes further into covering more of the gram-negative, but it might not cover some gram-positive as much. They do still cover gram-positive like Streptococcus pretty well, and that's why we kind of use it for pneumonia, and but they have a lot more coverage. The spectrum is bigger in terms of covering gram negatives, which is one of the examples is E. coli. So that's why in this case, ceftriaxone, if available, and it is very commonly available, commonly used in the clinical setting, then you would definitely want to choose the ceftriaxone more over cefazolin, right? Even if the lab tells you that cefazolin is susceptible to E. coli, it doesn't mean it might be the best choice. When somebody's doing cultures, typically, you get samples of the tissues of the, in this case, it's a wound culture, right? He also have blood culture. So you're getting blood and then kind of like getting that blood samples grown into a media or like a plate agar, so to see like if any bacteria grows in there, right? And then in that agar plate or media plate, you will kind of put in some antibiotics. So they will do like different concentration of antibiotics, and then they give you the MIC, essentially, like minimum inhibitory concentration, where the lower it is, the better, just because they need less potent. That means like if you're, if you have a lower MIC on one antibiotic, that means like it can be very potent for the bacteria that you are trying to see if it's susceptible or not. If it's like a higher MIC, that means like they need a higher dose, right, to inhibit the growth of the bacteria, which means like it might not be as well or as susceptible as the other ones that might have a lower MIC. So if you kind of think about MIC, it's kind of like how it works, or like how to define it. And then for susceptibility, intermediate, susceptible, or not susceptible, or resistance, those comes from the MIC number. So the lower it is, the more susceptible. But again, it goes to, the back to your antibiotic selection. We typically won't use cefazolin at all for E. coli, even if it's, a bacteria it has been shown to be susceptible. Sometimes the susceptibility threshold might be different as well from assay to assay, from hospital to hospital. So MIC might be higher in one hospital versus another. Again, it all depends on how the hospital, set their assays and set their cultures. So, you can't just follow whatever the this is cultures kind of tell you. Like if you have to sort of use a clinical judgment as well. Like for your perspective, like, do you think you would use cefazolin for E. coli? The answer is probably not. Like if you ask any medical professionals in the clinical setting, even if it shows susceptible. So again, in terms of selecting antibiotic, I would go straight to your spectrum. Use your clinical judgment first. And if you have lab, it's just kind of like confirming to you, like, oh, okay, the ceftriaxone is susceptible. If it's not susceptible, then you might have to exfoliate it. Okay. The third question is, a lot of facilitators mentioned to me that a lot of you guys are not aware that there is actually a bicarb on the third day of the admissions on, and bicarb just don't, you can get bicarb on other labs, not just ABG. So ABG, arterial blood gas, one of the facilitators was kind of mentioning to me, I think this might stick more instead of me, telling you where to find bicarb other than the ABG, is that some of the times you don't need, or, some of the times in the clinical setting, you don't always get the lab that you need if you can get it somewhere else and in easier way or more convenient way for the patient. ABG, if you Google it or even YouTube it, you can see how it's being obtained. It is invasive in comparison to getting venipuncture for your normal blood draw, like your Chem7 and CBC. So ABG is very painful. Like literally you are getting it from an arterial blood vessels, right? You get it from your wrist. It is hard to get. As much as we want, if we don't need to get it, we are not getting it. just for the patient's sake, and especially if the patient is not critically ill. And again, I would encourage you to go see like how ABG is being obtained, so it can provide some ideas on why we're not getting ABG multiple times daily. So when you're kind of trying to get like, okay, what other labs can we use, right, to see if DKA has resolved or not? One of it is bicarb, you know, like, so one is blood glucose for sure below 200, and then you have your anion gap that you can calculate. You have your pH, and then you have your bicarb. So bicarb, everybody, from what I heard, nobody mentioned about bicarb being a goal, you know, for DKA resolutions. And this come up a lot every year. I'm not sure why, because I asked the instructor for renal disease lectures and Dr. Maker, I believe, and she mentioned that she actually mentioned it during lecture. But you can also get bicarb from the CAM7, and it is equivalent to the CO2, the carbon dioxide. You know, bicarb is HCO3, literally an anion, right? And so you can pretty much, so CO2 is basically like the gas form of it. HCO3 is the chemical form, like more soluble form of it, essentially. Just like ammonium, ammonia, right? The gas is not soluble, but then when you make it into cation or anion, it becomes a soluble version. Like if you think back on your organic chemistry or even like gen chemistry, like think about like the equilibrium, you know, gas, liquid form, or like cation anion form, like it can kind of equilibrate one to another depending on how much concentration each of them have. You know, if the gas form has a lot more concentration, it will go it will try to maintain equilibrium to make more of the cation or the anion. In this case, like, you know, if CO2, you know, it can give you concentrations of the HCO3 just because they're equivalent. It's just different form. So again, I want you to know, you know, bicarb, you can use the carbon dioxide or CO2 from CAM7. So you don't even need to get ABG every day just to make sure the bicarb kind of goes down to normal again, right? And it's good for the patient, convenient for the patient, less cost to get any more labs, you know, less poking for the patient. So kind of like try to remember back, you know, when you're in the clinical setting, try to kind of review lectures to make sure you actually know how to get lab values. All right, and then the next one is some of the clinical pros I just want to reiterate or review. So I've heard from a lot of the facilitators, you know, some students are not addressing the cinecalcet. Some mentioned that the hypocalcemia that patient is experiencing is minimal, but you guys didn't mention about how about the hyperthyroidism, right? So in the case, if you look at it, the labs from, you know, a few months ago when they started the ESRD complications medications such as the sevelamer, the cinecalcet, and the ibudine alpha, you know, that was the baseline lab. And then now, like 3-6 months later, usually we should see changes if the medications are working or not, right? Because they have been on the medication for that long. 3 to 6 months are a pretty good amount of time to see changes in those kind of labs. So your iron, your hemoglobin, your phosphate, your parathyroid hormone. All of those, if the treatments are adequate, they should see some, or if the treatments are working, they should see improvements or like having them go back to goals, right? But in this patients, like it doesn't. If you look at the phosphate is still high, and they're still taking the phosphate, the phosphate binders, so you need to increase them because the current doses aren't working. And for the cinecalcet, you see how the calcium goes down, right? So that can be one of the adverse events of the cinecalcet. And then the parathyroid hormone is not at goal yet, right? So that's something to be addressed, not just kind of continuing and watch. You already have the lab, so you can do something about it and can address it. So that's what pharmacist's role is, right? You're trying to figure out what works or not. Like we're the one who monitor, who are able to interpret labs, and then help the doctor to kind of, realize that, oh, actually she was already on this medications before and it's been 3 to 6 months and they're not getting any better and they're not improving. We need to do something about it. Okay, so address something that you feel like it's not right, something that you feel like, oh, this needs to be taken care of, otherwise it's not going to, the patient's not going to get any better. All right. So the second point I want to mention is the fluid use in ESRD. So I think something to be careful for with patient with ESRD, especially these patients have uncontrolled hypertension. So a lot of blood pressure in there, right? So one of the cause may be like they're having too much volume, that can increase your blood pressure. And also like, those patients, and this patient especially, I think it's noted that this patient is not making any urine. So something to be cautious for in terms of this patients or patients who you think like might have fluid retention problem, like heart failure, right? Like those who have ESRD that cannot excrete fluid normally, they actually wait until dialysis to be able to get rid of any extra fluid that they need to get rid of. So be careful with your fluid. We don't want to fluid overload them and cause them any problem, right? We don't want to give them edema. We don't want to give them too many things going on. So this is related to like, one of the OB question mentioning about fluid use and decay, like something that's just something to consider. And then lastly, somebody's asking me, can you use PO iron, oral iron instead of IV iron, just because there is contraindication, right, with the IV iron in active infection? So what I want for you to do is to try to understand why is IV iron is contraindicated, or like, like it's recommended to be avoided when there is active infection. That's when you start having realizations and knowing like, why mechanism is or pathophysiology is important, right? So I hope everybody knows. I hope everybody's curious and looking up this answer. So IV iron, when you use it in active infection, there is it's hypothesized to sort of promote the growth and proliferation of the bacteria more. So it's an iron, it's a nutrition, so bacteria feed on it. So when you're giving the IV iron, there are reports of it that says that the infection is not getting any better, or like recurrent, relapse, yada yada yada. So that the IV iron is recommended to be avoided when there's active infection. That's kind of like the data that's out there. It's not like a randomized controlled trial or like anything that really prove the cause and effect of IV infection and IV iron and active infection, but there are just some reports, and that's why we are being cautious not to exacerbate the infection, right? So now the question is, how about PO iron, right? So again, going back to the idea why we are avoiding the IV iron, right? If I ask you now with that idea, would you give PO iron to this patient? Personally, and this is not right or wrong answer. This is a gray area where if you kind of look into the literature a little bit more, there is not much data out there for PO iron, and also kind of like, decide, like different provider might have different preferences. But personally, I wouldn't. Thinking about why we are avoiding IV iron, right? Because it's still an iron, it's still going to go into your blood, it might still go into your infection site and feed the bacteria, right? So if that's the reason why we are avoiding IV iron, then why are we giving them PO iron, right? Additionally, PO iron, you don't typically, it's not been shown to typically being efficacious, and patients who already have end-stage renal disease with like a pretty, it's a pretty end stage, and their anemia is not going to get better, right? The anemia itself is not just because of the iron deficiency, but it also like with the CKD, with the kidney not producing the erythropoietin and causing less production of RBC, right? That's what erythropoietin do. So with that mindset, like with their, like small risks of the PO iron exacerbating the infection, plus there's not much efficacy being reported or demonstrated with PO iron itself compared to IV iron. What is the benefit versus versus risk, right? So again, going back to your benefit, thinking through like what's the benefit if I give the IV iron? What's the risk if I, give the PO iron? What's the benefit and risk of the oral iron? So then going back, right? You don't just give something because you need to. And additionally, I feel like in this patient, his hemoglobin has been stable since, last time he got checked in 6 months ago. He's on the apoiodin alpha, I know it's not like a good time to kind of resume it while his blood pressure is uncontrolled. But again, there's no rush. He's not bleeding. He's not having the hemoglobin keep going down from last time, right? So that's another thing, right? Take a look at their presentations. Like, are they, are their anemia worsening? Like, are they, are they bleeding? Do they really need to give them acute management? Can we wait until the infection better, or even like keep them on the apoiodin alpha and after the blood pressure is controlled, and then just keep them until infection's cleared, they're not on antibiotics anymore, then we can start the IV iron, right? So a lot of things to consider on those stuff. Okay, so last parts, few announcement. The first one, I'm not sure why I still need to remind everybody about this, but I still get the note from the facilitators that some students are still using UpToDate for citing their arguments, citing their recommendations, citing their, plan. I think I've emphasized it a lot of times before in debrief and announcement. It's not appropriate to cite UpToDate. You can go to UpToDate, look at read the summary of, in terms of what you're looking for, but you still need to go to guidelines. Sometimes UpToDate is not that up-to-date. And you really need to go to guidelines to really ensure that you are getting the right information and not really giving false information. Misinformation is the worst. You can cause harm for the patient. If you're giving them the wrong information, you can cause errors, you can cause the wrong dose. You might be holding patients from an optimal medications if you're giving them misinformation. That's the worst thing that you can do as a pharmacist. Okay, so make sure that your information that you're recommending comes from reliable sources and it's 100% correct. If you are not 100% sure, do not give any recommendations, right? Because it might cause patient harm. So it's okay to say, I don't know, and you can take a look at it and really make sure that you're getting the right information. All right. The second one, I was sitting in one of the sections and I still hear that some students are spending more than 3 minutes on just reading their SNO. And I think that's another reason why I am having all the cases in the HR, so that it's harder for you guys to copy and paste the case. So the point of SNO is not to read every single lab notes, workup, HPI, from the case. You have to recognize what's pertinent for the problem, for each problem. Otherwise, then it's no use to have you do the SNO because you're just gonna read the whole case anyway, right? So keep in mind that you have 5 minutes for the presentation coming starting case 2. If you have like if you go over 5 minutes, the facilitators know to dock off points from your sub case, and that's in the RIC as well if you want to look at it. And again, your OSCE, similar to CB3, you only have 5 minutes. So, and that's a hard stop. So if you don't finish everything, you lose the point for the things that you miss. So practice, practice, practice from all the semester cases. When you go into rotations, your preceptor's not going to stay there and listen to you blabbering about the SNO for 15 minutes. They want to know your plan by minute 3, or even sometimes, faster, in like, by 1 minute, I need to know what's your plan, recommendation, rationales, and other things that are more important. So practice. I'm sure your facilitators somewhat note this as well. Maybe some of the facilitators do, some don't, but this is very important. Your preceptors are not as patient as maybe your facilitators. So, one of the good impressions a facilitator will get is if you're really on top of your presentations, and that's what they're expecting out of their didactic year when you go to ALPI. So yeah, so practice streamlining your subjective and objective. Lastly, be comprehensive. Again, I don't know why I am repeating this again. Some students are still missing some comprehensiveness. For example, your osteomyelitis patients, because of the osteomyelitis, are not ambulating well, not moving. Then what triggers you? DVT, right? You're not recommending it, then you're risking the patients to get DVT. That's another problem the patient will have if you don't recommend it. And pharmacists do recommend it a lot in the clinical setting. So remember about that. Patients still, in this time, the patient have pain, and there's no pain medication in the pain for the osteomyelitis, right? There's no pain medication being started. So you're just gonna let the patients be in pain for the whole inpatient management? No, right? You need to recommend pain management. All right, so be comprehensive. Think about, all the symptoms or signs that are related to the problem, and that can help you to figure out what do you need to do to make sure that you're managing the infection itself and also managing the signs and symptoms that resulted from the problem. Okay, all right, that's it for case 1 debrief, and we will see you in 2 weeks.